Heart snare polypectomy. So let me take you through some important history. If you read the editorial by Michael Shivak, editor-in-chief of GIE in 2004, entitled Polypectomy Looking Back, he poses a question about important milestones in endoscopy. And among all the milestones, he picks up heart snare polypectomy as the most important milestone. It has certainly revolutionized colon cancer prevention long before anyone realized about the impact of heart snare polypectomy. At this juncture, we should honor Dr. Hiromi Shinya, a Japanese colonoscopist, and Mr. Hiroshi Ichikawa, a Japanese engineer who worked for Olympus for developing the design, for coming up with the design of the heart snare and eventually making it. Interestingly, they drew the heart snare concept on the back of an envelope for gloves. The goal of snare polypectomy, the most important objective, is to prevent cancer, and you could achieve that by having a clean cut, clean of any residual polyp, and as well as a safe cut that is not associated with any complications like bleeding or perforation. Although that is the goal, if you look at the reality, we are not there. We have learned several lessons in the paradigm of colon cancer prevention using snare polypectomy. The first lesson in a large study published by Dr. Robertson et al. That 20% of interval cancers develop because of an incomplete polypectomy or incomplete snare polypectomy. Another landmark study by Dr. Heiko Pohl revealed that as the polyp size increases, our ability to cut completely also worsens. So, for a polyp between 15 to 20 millimeters, the rate of incomplete resection could be as high as 20%. In another interesting study, where several endoscopists from a major endoscopy center or academic center in the USA looked at the competency of several physicians and found that the competency for polypectomy is lacking. If you look at polyps less than 6 millimeters, the competency is 70%, and when you go beyond 6 millimeters, it drops to 50%, and if it comes to flat lesions, it is even worse, about 40%. It's also interesting that the same group has shown that if you give a report card to the endoscopist, their competency improved, but that was limited to less than 6 millimeter polyps. So how about the large polyps, where it all matters a lot more? My impression is, in order for us to improve the quality of polypectomy, we should all learn and practice a good scope tip control. What it means is not rushing to the cecum as we are performing the colonoscopy in 60 seconds, where we push all the scope to the point that we cannot move the scope tip in whichever direction we want, and that is essential for polypectomy. Instead, our goal should be to reach the cecum with a relatively short straight scope at 60 to 70 centimeters. How do you know whether you reach the cecum with your scope relatively straight? You could check yourself by rotating your scope and moving the position of the ileocecal valve from 3 o'clock to 12 o'clock, then to 9 o'clock, then to 6 o'clock, and if you could even bring it back to 3 o'clock, you know that your scope is straight with no loops. And this is essential for polypectomy. A short scope to the cecum allows you to stabilize the scope, and it also allows you to position the lesion where you want it to be for a safe cut as well as a clean cut. So when you look at a lesion on the video monitor, you should be able to bring the lesion to the lower one-third of the field. And this is where polyps can be best cut, and this is where you can see better and manage complications. Once you are ready to resect, before you jump and resect the lesion, you should assess the lesion. There are three important features that you should keep in mind before resecting a lesion. You should look at the surface for features of cancer using chroma-endoscopy. You should look at the edge for any skirt lesion so as to avoid incomplete resection. And you should also look at whether the lesion is dependent or not. If in case you use regular endoscopic mucosal resection, a dependent lesion could cause problems, especially if the lesion bleeds after the resection. So once you decide that the lesion is free from cancer and there's no skirt lesion and the location is not dependent, and you want to go ahead with snare polypectomy, you should appreciate the importance of colon wall anatomy. Among the 4 layers of the colon wall, mucosa, submucosa, muscularis propria, and serosa, submucosa is the strongest layer. If you preserve that, you'll come out safe with less risk or no risk of delayed perforation. In terms of the bleeding, as the vessels penetrate, go through the muscle, go through the submucosa, and reach the mucosa, the vessel caliber becomes less and less. So this is something to keep in mind when you're resecting. If you can increase the distance between your resection and large caliber vessels, you have less risk for delayed bleeding. In terms of snare polypectomy, should it be cold or hot? Let's look at the information. Let's look at the differences between a cold snare polypectomy and hot snare polypectomy. Cold snare polypectomy is a mechanical cut, and there is no blood vessel sealing. There might be a little bit of bleeding, but it will stop. But there is no heat sink into the submucosa, so you have no risk of delayed bleeding or perforation. However, hot snare uses both cut and coagulation, and there is immediate blood vessel sealing. The advantage of a hot snare is once you cut and if the vessels are sealed, you can see the lesion resection area and the edge so as to define whether you left any tissue or there. That may not be possible with cold snare when there is continuing ooze of blood. However, the disadvantage of hot snare is the heat sink into the submucosa and the risk of delayed bleeding when the SR comes out, and the risk of delayed perforation if there is unintended deep muscular injury. Coming to the heart snare, let's look at the basics. When you're performing a heart snare polypectomy, there are two elements, your snare and the heat generated by the electrosurgery unit. I've seen many endoscopy units where the endoscopist cannot see the parameters of the electrosurgery unit because it is located either to the right side or into the back, out of view, and that is not good. One thing we should do is to be able to see the electrosurgery unit right in front so that you could see your settings and select the most appropriate setting for a particular resection. At this juncture, I want to give some insight on different parameters that are used in electrosurgery unit. I use, in my unit, there are several different electrosurgical units. I would like to share what I use, and let's talk about EndoCut Q. What it does, it has three phases: an initial incision phase and a cutting stage, followed by a coagulation cycle. And these cycles go on till you achieve the result. There are three things that you need to understand. One is the effect, second is duration, third is interval. Let's talk about effect. There are three effect settings. Effect 1 has no coagulation effect. Effect 2, 3, and 4 have increasing amounts of coagulation effect. Something to keep in mind. If you want to have a pure cut, you can set it at effect 1. If you want to have some coagulation, depending upon where you want, you can go from 2 to 4. This is what will be the end result of having effect 1, that is a pure cut, and effect 4 has a lot of coagulation in addition to the cut. Let's look at the duration. Duration is the duration of the cut before a coagulation cycle starts. You have 4 settings, and for setting 1, you have a little bit of a cut. For setting 4, you have a lot of cut before this coagulation cycle starts. And let's look at interval. And as you can see here, typically we use an interval of 3, that is less than 3/4 of a second. If you go for 5 or 6, it is at 1 to 1.2 seconds. So you can actually change the interval if you want to have longer coagulation in between your cuts. So understanding these things is very important for heart snare polypectomy. And then the question comes, should you do traditional endoscopic mucosal resection or underwater endoscopic mucosal resection? So there are a couple of papers that came out recently. For 10 to 20 millimeter lesions, should you use a heart snare or conventional EMR, where you inject fluid, lift the lesion, and then cut? As you can see here, the results are better for larger lesions using conventional EMR. The next step is, how about conventional EMR versus underwater EMR for the same set of lesions? When it comes to en bloc resection, the underwater EMR has been shown in this study to have better en bloc resection and R0 resection. In summary, our mindset should be to provide a complete cut and a safe cut. And in order to do that, we should practice the scope tip control and be able to dance around the lesion for a safe and complete cut. Before you decide to cut, you assess the lesion, and if it is a small lesion, you could do a cold snare. If it is a larger lesion, cold snare may not be able to cut, in which case you need to use a hot snare. Learn the principles of electrosurgery, and whether you use traditional hot snare with submucosal injection or underwater EMR, you can choose depending upon your particular preference. Let me take you through a case. This is a large lesion in the rectum. We assessed the lesion, felt that there was no obvious features of cancer. Sometimes large lesions can have occult cancer that may not be identified on surface examination. That's a very small percentage of patients. Then you inject and lift the lesion and then perform hot snare polypectomy, and after the polypectomy examine the base to make sure that the resection is limited to the submucosa. If bleeding happens, you could control it easily either with a snare tip or with a coagulation forceps using soft coagulation. Once you cut, and as you cut, you need to survey your next cut and adapt the cut to the plane of resection, keeping the snare parallel to the wall. And that is critical to avoid resecting the muscle and ending up with a perforation. Here is a sequence of a parallel snare resection for a safe cut. As the lesion went beyond the fold into the proximal side, we ended up using underwater EMR for proximal resection. And as you can see here, using traditional EMR and underwater EMR, we were able to complete the resection. And although this patient had a little bit of delayed bleeding that was controlled with epinephrine injection, 6 months later and 18 months later, there was no recurrence. It was a benign lesion. In our experience over the last 10 years, we have taken care of over 281 patients of large lesions, low recurrence rate, low delayed bleeding, and none required emergency surgery for immediate bleeding or for any perforation. Thank you.